Hello and welcome to this video lecture on randomized controlled trial studies. These are also called experimental studies or intervention studies, and in medical and nursing contexts, clinical trials. In this session, we're going to explore the basic design aspects of randomized controlled trial studies. We're going to understand how and when to use these study designs, and we're going to look at the strengths and limitations of these studies. And in the apply session, we'll do some practical exercises. So, looking at the overview of the different types of epidemiological studies, we can see that randomized controlled trials fall into the group of studies at the top right called intervention studies. And in intervention studies, there are two broad types where you collect data and randomize at the group level, and you collect data and randomize at the individual level. Now, it's important to note that at the group level you also collect data at the individual level, but the randomization and the initial information collection happens at the group level. And these randomized controlled trials are called cluster randomized controlled trials or cluster field trials. Just like cohort studies, randomized controlled studies start, then move forward in time. We start with a control group and we have an intervention group, and the control group is the no exposure group and the intervention group is the exposure group. And the control group is not given an exposure, the intervention group is given an exposure, and we follow both groups up over time. And we think about bias and confounding factors. However, we don't just have to have two groups, we can have more than two groups. We can have, and we always have, a control group which doesn't have the exposure, and we have an intervention group 1, and we could have an intervention group 2 with two different types of interventions being studied, and we could have an intervention group 3 or 4 as well. And this way we can analyze the effectiveness and the value of different types of interventions in one study. So what are intervention studies? Intervention studies and randomized controlled trials are a type of intervention study. Investigate interventions. They investigate actions such as policies or programs or projects that help to change people's behaviors, their attitudes, and their perceptions. They can also change health outcomes as well. And key types of intervention studies are health promotion, health education programs, disease prevention interventions, and medical treatment such as new drugs or vaccines. Intervention studies can also be before and after, also called pre and post test, where the test is the intervention, longitudinal cross-sectional studies involving just one community. But we're not going to talk about those kinds of studies in this lecture. So how do we define intervention studies? Intervention studies are an investigation involving intentional change in some aspect of the status of the participants or subjects of a research study. E.g., we might give them a preventative health education teaching session, or we might give them a drug or some other therapeutic action. Or it could be an intervention designed to test some kind of theorized, hypothesized relationship between an exposure and an effect. And as I said previously, intervention studies are essentially experiments, and randomized controlled trials are also a type of experiment. So how do we define randomized controlled trials? RCTs are a clinical and epidemiological experiment in which subjects are randomly allocated, randomly divided into 2 or more groups, usually called test or intervention group or groups, and a control group or control groups, to receive or not receive a preventive or therapeutic procedure or intervention. The results are assessed by comparison of rates of disease, death, recovery, or other appropriate health outcome in the 2 or more study groups. Randomized controlled trials are generally regarded as the most scientifically robust method of hypothesis testing, often called the gold standard research method in epidemiology and medicine. However, they do suffer from certain issues such as lack of generalizability due to the non-representativeness of the participants who often get involved or offer to support randomized controlled trial studies. For example, most drug trials tend to have younger people and men offering to get involved compared to those from ethnic minority backgrounds, those who are older, and those who are women. As I said previously, just a reminder, randomized controlled trials are also called experimental studies. So in some papers, the study is called an experiment rather than a randomized controlled trial, but they generally mean the same thing. So what is a field trial and a community trial? Well, unlike clinical studies, field trials are epidemiological or clinical studies conducted outside clinical and laboratory settings in the general population. They are on-the-ground studies, field studies, hence the name. Most public health studies are like this. Community trials are a specific type of field trial, an experiment in which the unit of allocation to receive a preventive, therapeutic, or social intervention is an entire community or organization or part of a community or an organization. Again, most public health studies tend to be community trials of one kind or another. Important to remember that community trials are also called cluster randomized controlled trials, again where the unit of allocation is at the level of the community or group, village or town, and we'll look at this in a later slide in more detail. Clinical trials are medical studies, only some of which are randomized controlled trials. A clinical trial is a research activity that involves the administration of a test regimen, a drug treatment often, or a vaccine, to humans to evaluate its efficacy, its effectiveness, and its safety. Efficacy and effectiveness are generally the same thing and seen as the same thing. The term is broadly polysemic. What that means is it includes things that are not randomized controlled trials. For example, the first test of a drug in humans without any controlled treatment, right up to a very rigorously designed randomized controlled trial. So clinical trials are not always randomized controlled trials. There are generally 4 phases of clinical trials. Phase 1, which is the first test of a drug in a small group of humans to determine its safety and how it works in the body. It usually involves some healthy volunteers and focuses on the safety and pharmacological aspects of the, for example, drug treatment or the vaccine. Phase 2 trials are pilot efficacy studies, and they are the first attempt to look at the effectiveness of the drug treatment or vaccine, and it will continue to look at safety as well. But again, subjects tend not to be randomly allocated to an intervention group or a control group. Phase 3 trials are the start of extensive clinical trials. And it's at this phase that you tend to have randomization and a control group and an intervention group. It will also involve a large number of volunteers and participants. And then lastly, a phase 4 trial is a post-marketing clinical trial, often conducted after the treatment has got approval, and the aim of this is really to better understand the treatment and to understand the incidence of rare side effects and the potential value and long-term use of the drug in a real-life setting in health clinics and hospitals and settings. So what kinds of randomized controlled trials are used in public health? Well, we have two broad types: individual level RCTs, where participants are chosen individually one by one and then randomized one by one into a control group or an intervention group, and cluster randomized controlled trials or community trials, where participants are chosen in groups based on whether they are part of a village, town, city, neighborhood, hospital, outpatients, health clinic, factory or office. The group is chosen and then the group is randomly allocated between the control group and the intervention group. And then from those group level participants, individuals are then given the control intervention or the main intervention that we're interested in, such as a drug, a vaccine, or a health promotion intervention. What are quasi-experimental study designs? When some aspects of a randomized controlled trial cannot be undertaken, then the study may not be a proper randomized controlled trial. And therefore, these studies are labelled quasi-experimental studies. These studies often have a control group and intervention group, but they often may not have randomization, or they may not have blinding or masking. And there's two types of blinding and masking. The first one is blinding or masking of participants, so they don't know which intervention they've got. And the second one is a blinding and masking of the research team, so they don't know which intervention participants have got. When this is not possible, there is a possibility that information bias may be generated. When both types of blinding are present, the randomized controlled trial is called a double-blind randomized controlled trial, and when only one is present, it is called a single-blind randomized controlled trial. So let's look at how a cluster randomized controlled trial works. So we may choose, purposely choose or randomly choose a number of villages, towns in a region of a country that are likely to have similar types of residents. And then we're going to randomize at the group level. So we're going to randomize the villages in this case, or hospitals, or areas, or neighborhoods, to the control group, the intervention group 1, or the intervention group 2. Then participants from the control group villages and the intervention group 1 villages and the intervention group 2 villages are then studied. In contrast, individual level randomized controlled trials randomly select a number of individuals from villages or towns directly, and then once we have those individuals, we will randomize those men, women, or children. So let's look at how randomized controlled trials work. So we start off with our population, and then we choose either randomly or purposefully our study population, and ideally we want it to be a representative sample of our wider target population, but often that's not the case. And then we randomly choose some of our study population participants to get the intervention, to be the exposed group of people, and then we randomly choose some of our study population participants to not get the intervention and to be the not exposed group of people. And then we find we have a number of participants who are exposed in the intervention group to the intervention and have a change in health outcome. And we then have a number of participants who have been exposed to the intervention in the intervention group, but with no change in health outcome. And then we have number of participants in the control group with no exposure to the intervention. They haven't got the intervention, but there is a change in their health outcome. And then lastly, we have a number of participants with no exposure to the intervention in the control group and also no change in health outcome. And participants are generally followed up before and after the intervention, and this could be for 3 months, 6 months, 12 months, or 24 months. So what are the key elements of randomized controlled trials? They're intervention studies, so they allow the researcher to decide who is exposed and who is not to the factor or the intervention, the drug, the vaccine, or the health promotion activity that we are interested in. And therefore we need to ensure that the two groups, the one that gets the intervention and the one that does not, are similar. And what we then do is we randomly assign people to those two groups from the original study population that we have recruited. Intervention studies are therefore the closest epidemiological, medical and public health studies that we have that are similar to laboratory experiments, where we change one factor and try and keep everything else exactly the same. And this helps to reduce confounding, and it also reduces bias. Now, both confounding and bias will be there to some extent, but they are, compared to the other types of studies we've discussed previously, ecological studies, cross-sectional studies, cohort studies, and case control studies, randomized controlled trials have much lower levels of confounding and bias if done correctly and well. So let's examine the key elements or steps in the process of undertaking a randomized controlled trial. So we'll start with a hypothesis, an aim, and a set of objectives, and then we will define the broader reference population, and then from that reference population we'll recruit and select a study population, and we will have inclusion and exclusion criteria for what kinds of people we are willing to accept onto our study, and where we have invited people who don't meet our criteria for inclusion, then we will reject those unsuitable participants, and we will continue on with our suitable participants and subjects, and then they may refuse or decide not to take part at this stage and drop out of the study. Then we would take informed consent. We would take some key baseline measurements before we undertake the intervention, and then they are randomly allocated to the control group or the standard group or the placebo group, and they are also randomly allocated to the treatment group or the intervention group. And these Participants in the control group and in the intervention group are followed up over time. Again, there will be people who leave the study and drop out, and we will continue to monitor how many people drop out, and then we will take regular assessments of the key thing we are interested in, the key health outcome, during and after the intervention. And we will also look at things like compliance. Are people actually doing the program, or are they turning up? Are they taking the drug or not? And then we will do an analysis of the difference between the two groups, between the control group and the intervention group, and we will do some statistics and make some interpretations about whether there is an important difference, a statistically significant difference between the two groups. So how do we choose a RCT population? Well, at the individual level, we start with a target population, the population that is of interest and that we hope to study and apply the findings of our randomized control trial to. And it could be all people with a certain disease, such as hypertension, high blood pressure. It could be people of a certain age, like all children under 1 year old. Or it could be by ethnicity or sex or some other characteristic of the people in that target population. And from that target population, we will get the study population. We will recruit people to our study. And often this is more limited than the target population because it's often conducted in a specific geographical location. So while we might try for representativeness, often we won't get it in randomized controlled trials. The other thing we look at is what kinds of people do we want in, and often because of the type of thing we're doing, the intervention that we are exposing people to, we need to be very clear about what groups of people we can't have in our study. So this is an example of a vitamin supplement or micronutrient supplement intervention in adults who are infected with HIV in Thailand. And the inclusion criteria for participants or patients who get involved in the study are they have to be 18 and over, and that's helpful because from an ethical perspective, when we're doing studies, children require more sensitivity and more ethical supervision, and they have a CD4 white cell count that's greater than 100 cells per microliter. They live within 20 kilometers of the hospital. They are able to provide accurate details of their address. They agree to return for follow-ups, and they have consented to participate in writing. So you can see here that they need to live near hospitals because that's where the therapeutic intervention will take place, and the researchers want to know where people live, again to track them and to understand their socioeconomic background. And they are excluding participants or patients who get involved in the study who are already taking vitamins. And again, that makes sense. If you're already taking vitamins, then you're not going to get any benefit from coming onto the study. And the other thing they've excluded is participants who are already taking combination antiretroviral therapy. And again, because there may be interactions between the vitamin supplements and the antiviral therapy and drug treatment. And just to bear in mind, the inclusion criteria are not the opposite of the exclusion criteria, or the exclusion criteria are not the opposite of the inclusion criteria. So we don't say inclusion is aged 18 or over and exclusion is under 18s. We actually have specific exceptions to the above. So a person could be aged 18 and over, have a CD4 count greater or equal to 100 cells per microliter, live within 20 kilometers of a hospital or the hospital where we're going to do the study, can provide details of their address, will return for follow-ups and has consented, but if they are taking vitamins, then they can't take part. And if they are taking antiretroviral therapy, again, they can't take part. So you can see here, the exclusion criteria are specific exceptions to the inclusion criteria. So often the inclusion criteria are met, and then you use the exclusion criteria to remove certain types of people from that included group. We've already looked at an example of randomization at the individual level, but here it is in relation to this study of HIV-infected adults in Thailand and vitamin supplementation. And so we identify HIV-infected adult patients in a hospital. We select an appropriate number that we've thought about using some statistics to see what numbers we might need to show an effect. And in this case, they've chosen 600 patients from the hospital, and they've then randomly assigned 300 to get the vitamin micronutrient supplements and the other half to not get anything, to get a control supplement, a fake placebo tablet. And then over 24 months they count how many participants get AIDS. But if it's a community or a cluster that is being studied, and this is an example of one, which is community randomized trial to evaluate comprehensive sex education delivered in schools to school children to reduce HIV incidence. And so the choice, the participants are 246 primary schools within 4 districts, each having about 450 children in the last 3 years. And from that they select 60 primary schools and they stratify by HIV risk. So the researchers have identified whether the risk in that community school is high or low. So roadside would be high and a remote would be low, because roadsides are where there's lots of people, there's lots of mixing, and so there's a potential for a greater amount of sexual activity, whereas in a remote region, in a small village, in a rural area, the potential for increased sexual activity among a large number of partners is reduced. So those 60 primary schools are then randomly allocated to the intervention group and the control group. So in this case, 30 schools using the stratified sampling approach receive the comprehensive sex education, and the other schools just continue with their whatever sexual health education they were currently giving. And then they followed that up for 5 years and looked at how many new HIV infections were linked to the schools, and hopefully they would find that the comprehensive sex education program had a lower rate of new HIV infections compared to the 30 schools that did not get the intervention and were just using their standard sexual health program or no sexual health program. So how do we define and measure exposures in RCTs? Well, it depends on the exposure, and that relates to what the intervention is. And again, how it's measured depends on what the intervention is. It generally is easier because we know what the intervention is, we know therefore what the exposure is, and we are deciding what it is, and we are then able to then collect information. So we're going to decide on the exposure based on how we can measure the exposure. And so there's 3 broad types of exposures we might look at. Intention to change behavior, which is, for example, intention to use condoms or intention to do more physical activity after some kind of educational intervention or program or project. Or it could be an actual behavior change, such as increasing the use of breast screening following text message education intervention. Or it could be change in individual population health outcomes, for example, change in blood pressure or loss of weight in individuals after a yoga intervention, or changes in the number of cancers or deaths at a regional level or a country level, or deaths from heart attacks after reduction in exposure to air pollution due to creating a low emission zone that increases the use of electric cars and reduces air pollution in that low emission zone area. So what are the aspects around measuring the exposure? again, like previous discussions about epidemiological studies, we must develop clear criteria for what counts as an exposure, because, for example, it might be a 12-week program and participants may only attend 4 of the 12 sessions. Would that count as an exposure, or would you need them to come to all 12? What kinds of activities might they take part in the intervention? Are they taking part in those activities? And if not, again, how does that count? Is it an exposure or is it not? Exposures may be binary. Yes, they attended the intervention, or they didn't, or graded that they attended 4 of the 12 or 8 of the 12 or all 12, and see whether there's a difference in the levels of exposure and the levels or changes in health outcomes. Exposure measurements will not be the same between the intervention group and the control group, because the intervention group is getting the exposure and the control group is not getting the exposure. And similar to previous discussions, you can use self-completed questionnaires, physical measurements of the person or their environment, or routine statistics like census data, specific censuses, cancer registry or surveillance data, local health profile data. And this is collected before the intervention and then after the intervention is carried out. And just looking at some examples, so if we look at intention to change behavior, that could be through a self-completed questionnaire that I'm intending to use condoms more often than previously. We could measure actual behavior change, and that could be statistics on changes in the numbers of women using the breast cancer screening service. And so we get data from the breast cancer screening service about how many women attended. And then we could also do physical measurements such as physical activity using an accelerometer or pedometer. And we could also look at changes in individual or population health outcomes, such as changes in blood pressure or loss in weight. So we could use medical equipment such as a blood pressure monitor, or we can use simple equipment that we have at home like a weighing scale. Now, measuring health outcomes in RCTs is similar. You must develop clear criteria for what counts as the outcome. Measurements must be done identically between the exposed and the not exposed study participants. And the outcome measurement instruments, again, can be self-completed questionnaires, regular screenings and physical examinations, or some other kind of objective measurement, and also using routine information such as death certificates, medical notes, and cancer registries and other local health statistics. And these are collected both before and after the intervention. So now let's look at how we can measure association in one group. That is, calculate the risk or the odds for each group of participants, the exposed intervention group and the not exposed control group. So again, we start off with our population. We recruit a study population. We then randomly choose our group of participants who are going to be exposed, and we'll put them in the intervention group. And then we'll randomly choose our participants to not be exposed, and they'll be put in our control group. And so we'll have a number of participants being exposed in the intervention group but with a change in health outcome, and then a number of participants being exposed in the intervention group but with no change in health outcome, and then a number of participants in the control group that have not been exposed to the intervention but who also have a change in health outcome. And then lastly, number of participants without the exposure to the intervention in the control group but with no change in health outcome. Now, I hope you've realized from the last time I showed you this diagram that the change in health outcome is green and the no change in health outcome is red. And the reason for that is we are not going to make people worse to have a disease, to become ill. We're going to be improving their health outcome. So the change in health outcome that we're generally looking at is a positive change in health outcome. And so in the intervention group, we want people who have a health problem or a health issue or a risk to reduce that risk, reduce that health problem, reduce that disease. And hence that we have participants who have a positive change in health outcome and some participants who have no change in health outcome, so it continues to be a negative health outcome for them. And then we can calculate the risk or odds of the change in health outcome, the positive change in health outcome in the exposed group, the intervention group. We can calculate the risk or odds of change in health outcome, positive change in health outcome in the not exposed participants in the control group. And then we can look at the same diagram and then think about risk ratios and odds ratios. So we have our population. And we have a number of participants being exposed in the intervention group and with a change in health outcome. Number of participants being exposed in the intervention group but with no change in health outcome. Then a number of participants with no exposure in the control group. They've not been exposed to the intervention, but they have had a change in health outcome. And a number of participants with no exposure in the control group, no exposure to the intervention, and with no change in health outcome. And we can calculate the risk and odds in the intervention group and the risk and odds in the control group. And then if we divide the risk and odds in the intervention group by the risk or odds in the control group, we get and we calculate the risk ratio or the odds ratio between the number of participants with a change in health outcome, a positive change in health outcome in the exposed intervention group, compared with the number of participants with a change in health outcome, a positive change in health outcome in the not exposed control group. You can look at an example here of a 12-week yoga program, and the health outcome is normal blood pressure. So in this context, we're actually going to choose a special type of population. We're going to actually choose a study population of men and women with high blood pressure but no other health problems. And so we're not actually choosing a representative group of people that relate back to the wider population, and this is because of the type of intervention we're interested in. And often in RCTs we're interested in people with health problems because we're trying to do something to improve their health, and this is different from cohort studies, case control studies and cross-sectional studies, where often we're looking at exposures first and then seeing if people get a health problem. Here we can often start with people with a health problem and we're trying to change it, improve that health problem. So we have an exposed group of people in the intervention group who've been randomly chosen, randomly selected, participants with high blood pressure who get the 12-week program. And then we have another group of not exposed people who are randomly chosen, who are participants again with high blood pressure, but who only get the usual care from their doctor. They don't get anything else, just the normal care that their doctor gives them. And then, so in the intervention group, we can look at the number of participants being exposed in the yoga group to yoga and who then find they have normal blood pressure, and the number of participants being exposed in the yoga group to yoga but who continue to have high blood pressure. And then in the control group, we have the participants who are in the usual care group who have not done the yoga program, but they also have normal blood pressure. And the number of participants who, again, no exposure or part of the usual care group, haven't done any yoga, taken part in the yoga program, and they still have continued high blood pressure. And so we can calculate the risk or odds of normal blood pressure in the exposed yoga intervention group and the risk or odds of normal blood pressure in the not exposed usual care group. Now we could convert this into high blood pressure as well. You could do it either way, but normal blood pressure is what we're interested in, so we're going to put normal blood pressure as the outcome for the risk and the odds. And then we can calculate the risk ratio or the odds ratio between the number of participants with normal blood pressure in the yoga intervention group compared with or divided by the number of participants with normal blood pressure in the usual care control group. So there are four broad types of associations we can look at. We can look at absolute risk, risk ratios or relative risks, odds ratios, and absolute and relative risk reductions or risk differences. So absolute risk is what it is. It's just the risk or the odds, but we're not that interested in odds on its own. Odds ratios are useful, but risk on its own for one group is more useful than the odds in one group. So let's look at measures of disease occurrence in more detail. So if we look at risk, either looking at the intervention group or the control group, then risk in the intervention group is the number of participants who get the health outcome, for example, normal blood pressure in the intervention group, divided by the number of people exposed to the intervention at the start of the research study in the intervention group. And then the same calculation applies for control groups. The number of participants who get the outcome, normal blood pressure, in the control group, divided by the number of people not exposed to the intervention at the start in the control group. Because remember, none of the people in the control group have been exposed to anything. And then odds are the number of participants who get the outcome in the intervention group divided by the number of participants who do not get the outcome in the intervention group. And similarly, the number of participants who get the outcome in the control group divided by the number of participants who do not get the outcome in the control group. Now, when we're comparing two groups, that's when it becomes a ratio, because you're dividing one number by another. And so the risk ratio would be risk in the exposed intervention group divided by the risk in the not exposed control group, and the odds would be odds in the exposed intervention group, odds in the not exposed control group. And the risk difference is even simpler. It's essentially a subtraction. So the risk in the intervention group before the intervention and the risk in the intervention group after the intervention, or the risk in the control group before the intervention and the risk group after the intervention. And of course that's not that useful. What's more useful is the risk ratio difference in intervention, comparing the intervention group with the control group. So you have the risk ratio in the intervention group compared to the control group before the intervention minus the risk ratio in the intervention group compared to the control group after the intervention. So it's the risk ratio before the intervention takes place and the risk ratio afterwards, and you subtract one from the other. And that's a risk difference or risk ratio difference. So let's move on to the strengths of randomized controlled trials. They're more controlled than cohort studies, and therefore you can control for things like confounding and bias, and we'll discuss these in later video lectures. They take less time than cohort studies, and they account for confounding because of the random allocation, the randomization of people, the individuals or the villages, towns, the cluster between the intervention group and the control group, so that we are randomizing the different types of biases, the different ages, different ethnicities, different socioeconomic backgrounds across the two groups. So the only thing that's different between the two groups should be just the intervention. And we also use blinding or masking to hide the key information from participants and researchers, so that we reduce participant and researcher information or measurement bias. However, there are some key limitations of randomized controlled trials, and these are: there is still a potential for selection bias, especially at the beginning, because we don't randomize participants at the very beginning. We randomize after we've recruited them, and then we randomize to the two groups, the intervention group and the control group. So there's often a chance, as I said previously, that the types of people who take part are younger men and from a white ethnic background. So they may not be representative of the wider target population, and so our findings may not be generalizable to that wider population. Similar to cohort studies, they need high participant rates and good follow-up of participants, because if we lose people from the study, then that again will cause a selection bias in our study, because we don't know why some people have left, and maybe those people are very different from the people who have stayed. For example, it may be that all the poor people leave the study because it takes them too long to get to where we are doing the study, and maybe because there's a disruption to public transport as we are running the study. So those kinds of selective differences will lead to some selection bias. And we may also have some information bias, where we're getting information either through blinding and masking, but also through collecting information through questionnaires and other things, that we may get some recall bias, which is one type of information bias. And the blinding and masking will lead to a measurement bias, where we're not measuring what we were intending to measure, because the researchers and the participants know what group they're in, so they may start behaving in different ways, and so they are changing the things that we are looking for. And lastly, there are some key ethical issues with randomized controlled trials. We can only give positive exposures, and we can only do them in positive ways to improve people's health. We can't give them harmful exposures and cause disease. For example, we can't give participants a pack of cigarettes a day and see how and when they get lung cancer. And the other issue is around the ethics of giving some people an intervention and not others. And an example of this was in the 1980s and 1990s, exemplified and shown in the movie Dallas Buyers Club, where Matthew McConaughey was a gay man with HIV, and he created a club where he bought drugs, and some of those drugs came from randomized controlled trials that were taking place, and participants would try and get the drugs from the people who were in the intervention group if they were in the control group, and thereby invalidating the study, but also showing the kind of ethical issues about not giving potentially good intervention to some people in order to better understand and make sure that an intervention is effective. Now, this is a really nice video. We'll put that on Blackboard. Please have a look at it. You can search for Greg Martin, RCTs and confounding, and find this. Just to finish off, let's have a look at an example of a randomized controlled trial and its aims, objectives and its design. And this is a 5-day plan for smoking cessation. So the aim is to evaluate the effectiveness of a 5-day plan in helping smokers to stop smoking. And it's a randomized controlled trial comparing an intervention group and a control group. And the primary outcome measure was 12 months of continuous absence or abstinence of smoking, verified by using carbon monoxide monitor, where the smokers will blow out air into it, and it will measure their carbon monoxide levels in their air that they expel, and this will tell us whether they have been smoking in the past few weeks and months. And the secondary outcome measures were self-reported abstinence at the end of treatment and at 3 and 6 months. So essentially they were looking at two types of absence of smoking or abstinence from smoking. One is at 12 months using an objective measurement device and a carbon monoxide monitor, And the secondary outcomes were self-reported, so they could lie potentially, reported absence or abstinence of smoking at the end of the treatment program and at 3 months and 6 months. And so the setting was 6 towns in France. They recruited 228 smokers via newspaper and radio adverts, and these were aged 18 years or over, and they were interested and willing to quit smoking. Because again, there's no point including people who are not interested in stopping smoking, because that again would bias your study. And so the intervention group had 119 participants, and they all received the 5-day plan, which was a behavioural group-based treatment program that has been running in France since 1965, and it involves 5 consecutive evenings of this therapy sessions, group therapy sessions. And the control group had 109 participants, so you don't have to have equal numbers, but reasonably equal numbers is what you're aiming for. And they received a single session discussing the health effects of smoking, just health education teaching session. And the findings were that in the intervention group, 67 participants, 56% of them quit smoking at the end of the program, and at 3 months this had gone down from 56% to 25%. So some people had started smoking after the intervention, and that reduced to 16% by the end of the year. So you can see here, immediately after the intervention, 56% quit smoking, and then unfortunately 31% then went back to smoking, and then by the end of the year the majority, 84%, had gone back to smoking, and only 16% had continued to not smoke. While in the control group the numbers were much lower. They were 13% and 11% at 3 months and 12 months. So you can see here, while the results are a bit disappointing at 1 year, there is a bigger difference compared to the control group, and this was a significant difference in the two groups. So we'll be looking at the practical on randomized controlled trials in the apply session. I hope you've enjoyed this session, and I look forward to seeing you next time. Bye bye.